I thank the organizers for giving me this opportunity, and I will talk about the basics in thyroid imaging in nuclear medicine. So this is the outline of my topic as given by our organizers. I'll be talking about the radioisotopes and indication in hypothyroidism, thyroid cancer, especially papillary and medullary, and touch upon FDG PET and DOTA PET. Our previous two speakers have elaborately expressed these two topics, so it's easy for me to just go through. So coming to technetium, it's a radioisotope which has a half-life of 6 hours, and it is a pure gamma emitter. The imaging is done in the gamma camera. Iodine 131, as we all know, is having a half-life of 8 days. It has both gamma and beta emission. So technetium pertechnetate is what is used for the thyroid imaging. So technetium is trapped from the bloodstream into thyroid gland, but does not undergo organification like iodine. The dose is about 2 millicurie for whole body scan and about and it's given IV and it's acquired after 20 minutes. The advantage is that we don't have to have any special preparation that is required as compared to iodine, and it is not influenced by any recent procedures with iodine contrast substance. So the clinical applications in thyroid for technetium is when it is hyperfunctioning, especially hyperfunctional nodular goiter or AFTN, or hyperfunctional diffuse goiter such as in Graves' disease. And for hypothyroidism, secondary hypothyroidism, or a whole nodule, thyroiditis, thyroid cyst, or dysharmonogenesis. And anatomical variants like retrosternal goiter, ectopic thyroid, accessory lobes, agenesis, and thyroglossal cyst. So some of the imaging that you can see. The first I'm showing is a thyroid agenesis. You see that there is no uptake in the thyroid bed in a child who is about 2 months old. And this is an ectopic thyroid which is suprahyoid in location. And this is dyshomogenesis in a child who had a high TSH level. And dyshomogenesis can also be and the lingual thyroid. As you can see, as I put the marker there, you can see that both in the anterior and in the lateral view, I've put the marker for the lingual thyroid. All this can be done with the technetium thyroid scan. And coming to radioactive iodine, this is used to evaluate physiologic function of thyroid. And role in hypothyroidism is especially to identify patients for radioactive iodine ablation and to differentiate between thyroiditis and hyperthyroidism. In differentiated thyroid cancer, it is to identify residual thyroid post-op and to identify functioning thyroid metastasis and also for response assessment. We all know that iodine has been used in the medical field more than 8 to 9 decades, and I believe that it is there to stay with us. And what are the different isotopes that we know of iodine and what are its uses and where it can be used? Iodine 131 is the most easily available, and throughout our country we are using iodine 131 because of its ready availability and it is cheaper. And it also allows longer delayed image because the half-life is about 8 days. But the disadvantage is that we need to have some safety precautions for family and caregivers because it has both the beta emitting radiations. Whereas iodine 123 is the most ideal isotope for gamma imaging. It has good image quality. It's a pure gamma emitter. But the disadvantage is that it's limited availability and it's expensive. It's a cyclotron produced radioisotope. Iodine 124 is a PET emitter and has superior image quality. We can have fused image with CT or MR, but very limited availability and extremely expensive, not available in our country. So for all practical purposes, we use iodine. Coming to thyroid uptake study, how is it done? The patient is nil per oral for 4 hours and it is administered orally We use about 1 megabecquerel or 27 microcurie of iodine is given orally. The uptake values are calculated using a thyroid probe after background correction at 2, 6, and 24 hours. And these images are acquired after 24 hours in the gamma camera and the anterior view. So how do we interpret the uptake values? In normal subjects, the percentage of radioactive uptake increases progressively up to 24 hours. And in Graves' disease, it rises at a more rapid rate to higher levels, often even to 50 to 80%. But some patients with Graves have rapid iodine turnover within thyroid manifested as early rapid high uptake at 2 or 6 hours, but only mildly elevated or even normal at 24 hours. So this is the normal range. At 2 hours, it's 8 to 17%, 6 hours, 13 to 25, 24 hours, it is 23 to 40%. This is what we use in our institution. Where do you get increased radioactive uptake, iodine uptake? We get it in Graves, toxic nodular goiter, and hashitoxicosis. Decreased uptake can be in any of the thyroiditis and in struma ovary. In struma ovary, there will be decreased uptake in the thyroid bed, but it may increase in the ovaries. So how do we interpret this? If there is a high radioactive uptake and the imaging shows a focal or a solitary nodule, we can say it's a toxic multinodular goiter or a toxic solitary adenoma. If it is diffuse, more likely to be Graves, and if it is having low uptake, it is likely to be thyroiditis or some external drug interference or exogenous thyroid hormone. So what is a cold nodule? It's a hypofunctioning which when compared to the normal thyroid. And warm nodule, there's increased uptake but without suppression of extranodular tissue, like in non-toxic hyperfunctioning adenomas or hyperplastic thyroid tissue. And hot, when there's a hyperfunctioning nodule with suppression of extranodular gland. And what is the usefulness of this is in cold nodules, about 10 to 15% can be malignant. Whereas in hot, maybe it's less than 2%, 1 to 2% can be malignant. So what are the other conditions where you can get cold nodule is benign colloid nodule, simple cyst, hemorrhagic cyst, adenoma, thyroiditis, focal thyroiditis or abscesses or even parathyroid cyst or adenoma. This is a patient who was 26-year-old lady with complaints of loss of weight with increased appetite. Her TSH was suppressed and iodine scan was done, which is showing a diffuse uptake in both the lobes and predominantly more on the left lobe. And her uptake at 2, 6, and 24 hours was elevated. Clearly a case of Graves. Another patient, 60-year-old, had come in 2004 with a thyroid scan where we found that she had a cold nodule. She was lost to follow-up and returned after 13 years with cough and dyspnea, with progressive swelling in the same region. And a biopsy was done which showed polydifferentiated thyroid carcinoma, and this was her whole body scan with an elevated TG, and subsequently she was given ablation, and you can see slowly how it is decreasing and the TG is also coming down. So coming to whole body scan, why do we have to do a diagnostic whole body scan? We all know that actually less than or almost 1% of mastectomy is truly total. So if there are no remnants to be ablated, then ablating is futile. In patients who have brain or spinal cord mets and who require steroids to avoid complications caused by radiation-induced inflammation. So what are the pre-scan preparation? Thyroxine should be stopped for 4 weeks and T3 for 2 weeks. If there is possibility of recombinant TSH injection, they can be given recombinant TSH without stopping these hormones. Patients have to avoid iodine-containing food or drugs which interfere with iodine uptake, and no study should be done with iodinated contrast because we know contrast has an organic iodine of about 300 milligram per ml, and it will definitely interfere with the iodine scan. Patient has to be nil per oral for at least 4 hours prior to study. The absolute contraindication is pregnancy and lactation. So this is the standard protocol for recombinant TSH injection. On day 1 and 2, we give 0.9 milligram of deep IM recombinant TSH injection. Day 3, the dose is given, and after 48 hours, scan is done. This is not commonly done because of the cost that is involved with this. Now, how do I do a whole body scan? I said we give about 2 millicurie of iodine 131 orally. The image is acquired 48 hours later, both anterior and posterior views under the gamma camera. Now, this is a normal physiological uptake in the salivary gland, the nasopharyngeal area, stomach, bowel, and bladder. So patient who has had this whole body scan, one patient with small residual, you can see onto my left, and a bulky residual with so-called star artifact, it's called the bulky residual. And a patient who presented with, who was diagnosed with papillary carcinoma thyroid, ablated once, and the antibodies are negative. You can see the follow-up scan and the initial scan with a TG, with a stimulated thyroglobulin that has been steadfastly normal or negligible. In lymph nodal biopsy, we see this is a 31-year-old male was diagnosed with PTC with lymph node metastasis, and you can see in the first image done in right on top that the whole body scan, that the neck view showing a lot of residual uptake and lymph nodal uptake. On subsequent ablation, the scan shows decreased in intensity and almost normal towards the end. And this was his profile of TG that you can see it slowly decreasing, and patient was doing well.
I'm sorry to interrupt. Some yellow marker is there in on your slides. Actually, you can remove it. That one, some I think mistaken.
I'm not sure how that happened because no, this is somebody.
Okay, madam. Okay, then you proceed.
Just a minute, sir.
Dr. Sridhar, I will get that sorted with the organizer. Maybe we'll continue.
Thank you.
It is. It is.
Gone. Perfect.
Yeah, thank you. Yeah, another patient with lung metastasis is a 7-year-old boy who was diagnosed with advanced disease, and you can see that his whole body is showing uptake in both the lung fields, and subsequent follow-up, almost you can see that the lung fields have been cleared, and he's been followed up for more than 10 years now, and the thyroglobulin has also significantly reduced in another patient with liver metastasis. We know that isolated metastasis to liver from thyroid is very low frequency, less than reported cases are like less than 0.5%. This is a 25-year-old lady who was diagnosed with PTC, follicular variant, and when she came for the whole body scan, we found that she had a big tracer activity in the abdomen region. A SPECT CT was done, and that could localize the lesion to the liver. She was ablated, and you can see in the follow-up scan the thyroglobulin is also coming down, and the scan is also negative. Coming to osseous metastasis, 4% of all thyroid cancer patients can present with osseous metastasis. This is a patient who is about 60 years old, presented with extensive metastasis, and she was given a cumulative iodine therapy of about 500 millicurie. And you can see that there's a large lytic lesion which is seen in the X-ray, and that lytic lesion is taking up the intense iodine. So generally we see that bone metastases are a little indolent when we treat, especially if they are very extensive. And you can also see that the thyroglobulin is significantly going higher. And coming to post-therapy scan, why do we do a post-therapy scan? This is to assess the disease staging. and document activity of any structural disease. On comparing results of pre-therapy and post-therapy, about some in at least 6 to 13% of newly discovered lesions have been seen. This is a case of a 29-year-old patient who had diffuse sclerosing PTC. Her iodine scan was negative and thyroglobulin was going up, whereas the post-therapy scan showed mediastinal nodal uptake that was also confirmed with the SPECT CT that you can see below. Coming to positron emission tomography, we have listened extensively to our two previous speakers, so I will not go too much in detail about the mechanisms here. And what are the indications in thyroid malignancies only what I'll cover. The most commonly used isotopes are fluorine-18, that is cyclotron produced with a half-life of 110 minutes, and generator produced isotope, which is gallium-68 with a half-life of 68 minutes. These are the two PET tracers that are easily available in most of the nuclear medicine setups. So the commonly used F18 tracer is fluorodeoxyglucose, which is a glucose analog and which will enter the cytosol and gets phosphorylated to FDG phosphate. This gets trapped inside the cytosol, and this is the mechanism how we can image in the PET CT. The other tracer is other positron emitter I said was gallium-68 dotatate. So preparation for an FDG, the patient has to be fasting at least 4 to 6 hours prior to the study, and the glucose should be less than 150 milligram, and no strenuous activity prior to injection of radioisotope to avoid physiologic muscle uptake of FDG. And this is a physiologic uptake of FDG in the brain, salivary gland, and thyroid, lymphoid, mucosal, liver, and kidneys. And if skeletal muscles will be taken up if there is extensive physical activity. Now, what is the indication of PET FDG in differentiated thyroid cancers? The indication is high-risk DTC patient with elevated serum thyroglobulin and negative whole body iodine scan. This is needed for to make the decision whether they can be amenable for surgical excision or for further systemic therapy with TKIs or tyrosine kinase inhibitors. It is shown that if the thyroglobulin is more than 10, then there's 10% chance of FDG positive. But higher the thyroglobulin, more the sensitivity increases. And if it is iodine negativity, definitely the sensitivity increases to about 90%. Before terming a patient as thyroglobulin elevated negative iodine scan, that is tennis and short, we need to rule out iodide interference and false positive elevated TG related to anti-TG antibodies. So in our center, when a scan is negative and the TG is positive, we do what is called as empirical therapy, although it's quite a debatable option, and do the post-therapy and see if the post-therapy scan is positive or if there is a decreasing thyroglobulin trend in the follow-up, continue the treatment if it is beneficial. If the post-therapy scan is negative, do a PET scan to identify resectable tumor. This is a patient who was a 78-year-old lady who was diagnosed in 2010. Her iodine she has received ablations and her follow-up scan was negative, and she was found to have raising serum thyroglobulin. A PET CT was done, which showed an intense uptake in the thyroid bed, suggestive of a recurrence. SUV was around 16, and excision was done, and this was shown to be a recurrence with invasion to the skeletal muscle. Another patient was 60-year-old, similar story, and we did a PET CT. Her TG also was going up, and we found multiple lesions in the lung. So coming to incidentalomas. Incidentalomas are uptake in the thyroid gland, where you see when you are doing a PET CT for some other reason. So it is important to know whether it is focal or whether it is diffuse. So from our own data, we found that the focal uptake, when you do a biopsy or an FNA, the malignancy is about 50%. And so it's important when you find a focal uptake in the PET CT that you do, the patient has to be subjected to a tissue diagnosis before we negate that. Coming to medullary thyroid carcinoma, there are plenty of radioisotopes, but I'll be concentrating only on FDG and dotatate as given. And the mechanisms of uptake and localization of different radiopharmaceuticals are shown in this image. You can go through this. So about gallium-68 dotatate, we have already listened extensively by our colleagues, so I will not spend too much of my time. Now, gallium is a generator-produced isotope. It is produced from germanium generator. Now, germanium generator is about, germanium has about half-life of about 271 days. So it can be used in a department for close to a year. And the daughter product of germanium is gallium. And these are tagged with dotatate. As you can see, it's a chelator and a linker and a ligand. And the most commonly used is dotatalk, NOC, and tate. And in our institute, we use dotatate. So this is a physiological uptake that you see in a gallium-68 dotatate scan. And the most important reason why advantage of a dotatate is it is used to select patients likely to receive PRRT, and its positivity suggests it's a good prognosis marker of neuroendocrine nature of a tumor. So in medullary thyroid cancer, the sensitivity and accuracy is about 100% and 93%. And the detection rate is also increased with increasing calcitonin levels, 83% for a calcitonin of more than 500 or 1000. And although gallium dotatate PET-CT is not an optimal whole body imaging, it detects 100% bone metastasis, and it is far superior to bone scan. So these are the indications for doing an FDG PET-CT in MPC. You can see that elevated calcitonin or CA with negative conventional imaging, and we would like to see the response to treatment and post-surgical evaluation of residual disease, and sometimes initial staging and diagnosis. And the calcitonin level should be with above 500 and with a less than 1 year doubling time. There's an 18-year-old male swelling in the neck, underwent hemithyroidectomy, found to have MPC. And we did the FDG scan, and there was an uptake in the liver. And his calcitonin was progressively increasing along with the CEA. So the sensitivity of an FDG PET-CT is about 78% when the calcitonin is more than 1000.
I'm sorry to interrupt, Devi. May I summarize the 2 more minutes?
Yes, sir. So this is another patient who has been diagnosed with MIBG, and initially with MTC, initially we had treated this patient with MIBG, and we found that his calcitonin was still going up. And when we got the dotatate and we found that he had extensive disease, he was subjected to lutetium therapy but succumbed eventually. And in MTC, the most important tracer is F-DOPA PET. Although this was not within my purview of the class, I just want to pass a passing statement that DOPA PET is a very sensitive test for MTC with a higher patient-based and lesion-based sensitivity. I'd like to summarize my talk by saying that nuclear medicine imaging is an integral part of thyroid evaluation. It plays a key role in the functional evaluation and management of thyroid disease. With the multidisciplinary team and an integral part of each and every participant, we can together make the life of a patient very eminent. Thank you so much.